adenovirus, and everybody are aware of this adenoviral infection occurring rampantly in this part of this country, particularly in Kolkata. So WP has planned to sensitize all our members regarding the treatment, investigations, and how to counsel the parents. So first, I'll request our President, Madam, Professor Kalpana Datto, to start this program. Madam, over to you.
Thank you, Dr. Shapun Roy. Very good evening to everyone, and welcome you in this platform of a webinar on the adenoviral infections. And not only, as Dr. Shapun said, not only in the West Bengal, I heard from the central IIP, it is all over in the India, or even in the eastern part of India and Delhi also. There's quite a lot of adenoviral infections going on. Even I got a report from Chandigarh also. So this is going on all over India, more or less. The incidents are different. And this is not a new virus. That is a very important message to say. It is not a new virus. It is there. Every time we have adenovirus. And one thing I would like to say, from where we got this adenovirus name, because the 1953, it has been isolated from the adenoid or a human adenoids. From there, it has been said is the adenovirus. And now I'm not going to say many words because many speakers are there. At the end, we might say a few words after that. So I'll welcome the first speaker. I think first speaker is Dr. Dibendra Chaudhary or Dr. Shuman Poddar?
No, Dr. Shuman Poddar. So I'll
we're talking
Dr.
on clinical
Shuman
features.
Poddar.
Okay. Dr. Shuman Poddar. You just introduced the Dr. Shuman Poddar and
Dr.
speak on a
Shuman
hard topic.
Poddar is a consultant in Institute of Child Health, Kolkata, and he is also in charge of the molecular biology and the microbiology department. And Shuman is very much known face to all of us, actually. So I request Shuman to present the adenovirus and the normal clinical presentation. So now the screen is yours, Dr. Poddar.
Thank you, sir. Thank you, madam. And thank you, all my teachers. At the onset, I'd like to say that probably I'm also having the same. For the last 2 days, I'm down with fever and little bit of cough. Few of the features of adeno was there. Anyway, so to start with adenovirus and clinical presentation in a setting of adeno within the body. So without wasting time, let me start. Now, as madam said, this name came because this particular organism was isolated from human adenoids in 1953, and hence from there the name was coined. But this is actually a medium-sized virus, somewhere between 90 to 100 nanometer. It's non-enveloped. This is very important because all the means to kill the virus, to wash out the envelope, if that is our target, then it is not going to work as far as the disinfectant is concerned. So this is a non-enveloped virus without an outer lipid bilayer. That's got icosahedral nucleocapsid. Icosahedral is something like this. This structure is icosahedral, and this is the actual picture under electron microscope. Now, it contains a linear, non-segmented, double-stranded DNA genome. Now, non-segmented, this is very important. Why non-segmented is important? It's something that is not there in rotavirus, where it is segmented. It is not something like in the flu, where it is segmented. The genetic material is segmented. If it is segmented, then there will always be a chance of mixing and matching, and so that newer and newer entities may come out very easily. So that is not very easy in this particular scenario. So this is non-segmented double-stranded DNA genome, and it consists of somewhere around 22 to 40 genes, at least theoretically. So with this background, let me be a little deeper into the structure. If you see these structures, the hexane proteins, this is the main bulk of the capsid. These are the hexane proteins. These are the main structural components. Then comes this penton. This penton base pairs. These are about 12 penton bases are there. These are something like a cap, capping the hexons to make the structure icosahedral. On this penton lies this pin-like structure. This pin-like structure is called as a protruding fiber. Now, this fiber, this is the receptor binding site, and this helps in hemagglutination reaction. So with this receptor, with this fiber, it binds to the receptor. Then with this penton, it penetrates the cell, and then hexen get disassembled, and the other things happen. So that is the basic structure of the of this particular virus. So what are the receptors on the host cell? So human host cell, if they carry CD46 and CAR, that is Coxsackie virus adenovirus receptor, these two, either of these two has to be there for that particular organism to enter. Now, in the recent times, these two are added receptors that are being thought of. So MHC molecules and sialic acid residues, they can also aid this particular virus to come inside the cell. And how this happens, I'll not go into the details of the biochemistry and all. In a small term, the virus attaches with the specific receptor with the help of this fiber or this pin-like structure, and then with some mechanism, it is internalized in the form of endocytosis. As it goes in, after endocytosis, endosome is formed. Within the endosome, this virus is there, and there within the endosome, since the pH is little acidic, so because of the presence of this acidic pH, there is some disassembly of the this particular virus, and then the virion is released to the cytosol and being carried to the nuclear. These are the nuclear pores, and where the particular genes are introduced inside the nucleus. Within the nucleus, the virus starts doing its own activity using host machinery. So early phase proteins are first produced. These proteins, they regulate the further assembly or further replication of the genes. So then comes the second phase or the late phase replication or transcription, and this transcription, the different parts of the viruses are produced, and then there is virus assembly. Sorry. Now, with this, after this virus assembly, the total virus is formed, and then the virus comes out by lysing the entire cell. It doesn't come out just as it is. It uses the host machinery of this transcription, replication, and all this, and then come out by lysing the cell. This is very important. So cell lysis resulting in release of the mature virus. Why this cell lysis is important, I'll tell you in some later slide. Now, as per the literature, there are different genera. We need not to remember all these things, all these jargons. What we need to know, all the human adenoviruses, they reside in this particular group, which is called as must adenovirus. They not only affect the human virus, they also can affect other mammals. So currently, about 88 human adenoviruses have been identified. Of this, more or less 70 to 75 are more important. And how these serotypes are being made? By the hemagglutination pattern, phylogenetic analysis, and genome organization. So they have been analyzed differentiated into 7 such groups, and these serotypes are there. Now, the important thing, I already said that it's a non-segmented genome. So genomic mixing between the serotypes is not possible. But if it happens that 2 serotypes have infected the same host cell, then the fibers or the hexons that may be produced by both the viruses, both the serotypes. So there will be, suppose 3 and 7. These two are pretty predominant nowadays. Now, suppose the fiber of 3 gets incorporated into the cell of the 7. So there will be some mixing and matching as well, in spite of the thing that it's a double-stranded, non-segmented DNA. So the genetic material will be preserved, but the surface might be little changed. And as a result, some naturally occurring recombinant strains can be found. So containing fiber of one serotype and hexane of another serotype. And that is the main cause that may cause some mixed clinical manifestation. And that is the reason one particular serotype, how we are getting serotype by the use of evaluation test based on the fiber. So one fiber of one serotype, but the inner material is from other serotype. So there might be some mixed clinical manifestation, and that is the reason one particular serotype can have different manifestation in different host and different host cell. So a host of diseases can occur, spectrum of diseases. Mostly children are affected, be it acute febrile pharyngitis, pharyngoconjunctival fever. Now, these are the serotypes. You can see 1 to 7. These are affected, I mean, mostly associated with acute febrile pharyngitis. Now, 3 and 7, they are responsible for pharyngoconjunctival fever. Whether it will stay till pharyngoconjunctiva or it will go into something more beyond that, whether it will go into the conjunctivitis, just being a conjunctivitis, that depends upon the host immunity and host virus immunity interplay. For the adults, one particular entity that is called as epidemic keratoconjunctivitis, or in common terms, it was called as, once upon a time, it was called as sheep-eared eye. So this is very, very important because when it occurs, it is pretty painful for the adults and it is very, very contagious. Absolutely young kids, diarrhea can occur, but few of the serotypes can lead to hemorrhagic cystitis, interstitial nephritis, and so on. But when I was preparing the slides, to my surprise, I just came to know that there are certain serotypes which have been implicated with obesity or adipogenicity. I don't know what is the exact mechanism, but there are theories, and this is some hypothesis possibly. Some reports are there, but not conclusively proven. But it is thought that these 5 serotypes, they are somehow related to obesity or adipogenicity, but mostly in adults. Now, how it is transmitted? We all know that it transmits by droplets or aerosol. And that's the reason if we stay in close proximity, so it's a highly contagious disease, just like COVID. It can transmit. It will be transmitted very easily from one to another, and that's the reason why the kids are getting affected when going to school. It can be transmitted by fomite as well. Someone is having conjunctivitis, touching the eye, and that eye secretion or eyes, I mean, the tear that is getting transmitted to some desk maybe, and from that desk another child is harboring it to his own eye, and then the virus is getting transmitted. So that is possible. So it's transmitted by fomite. It can be transmitted by fecal-oral route, and the commonest one, it is transmitted by swimming pool or lakes. So that is why we usually see pharyngoconjunctival fever in the kids in the summer months. A little bit of pathogenesis. When this particular virus attaches with the mucoepithelial cells, there can be 3 types of reaction. It can be lytic infection, it can be latent infection, it can be transforming infection. Now, what is lytic infection? Lytic infection, as I said, the cell, the viral progeny, after multiplying within the local area, so local replication, then it comes out of the cell by lysing that particular mother cell, and that is very, very important. So cell lysis is occurring, and because of this cell lysis, if this lysis is too much, because of this cell lysis, there might be involvement of certain cytokines, and as a result of which there might be cytokine storm as well. And also maybe that is the result why the CRP in the inflammatory marker, one such as CRP, is high in many a times when dealing with cases of adenoviral infection. But dissemination mostly occurs in immunocompromised individuals. So after local replication, the viremia occurs and spreads to different organs. But wide dissemination, that is very rare in immunocompetent hosts. Next occurs the latent infection. How this latent infection occurs, that's a mystery. Not exactly known. It has the unique ability to remain latent in the lymphoid tissues, as for example, the adenoid, tonsils, Peyer's patch. And this reactivation will occur in some later days. And how this reactivation occurs, still not known. Maybe when the host immunity comes down, maybe when that particular host cell is affected by some other virus. So by some means, on some favorable time, this latent infection becomes reactivated. And the third thing that can happen, that is the transforming infection. Now this is the theory of oncogenicity. But as of now, no such things from the adenoviral group has been reported in human beings. These are reported in group A and group B adenoviruses in the rodents only. Now the immunity, how does it help? Both cell-mediated and humoral immunity comes into play. The CMI, they are mostly important in limiting the proliferation and outgrowth of the adenovirus. But it is the circulating neutralizing antibody that is mostly important. These neutralizing antibodies, they resist the clinical disease. And this immunity is long lasting. But remember one thing, antibodies protects the person from reinfection from the same serotype only, not with the other serotypes. Only from the same serotype, not with the other serotypes. So the immunity is long lasting. Definitely neutralizing antibodies are there in the host. Okay, but it is for the same serotype only. Cross protective immunity is not there by these antibodies. Now let's see the disease spectrum. Mainly children are affected. Mainly the disease, mainly the children are affected. Adults may be affected. Mostly if the adults are affected, they are just, maybe they are asymptomatically affected. Maybe they are just the carrier. Maybe they are affected in a minimal way. Until unless they have certain comorbidities, case fatality in adults are very rare. So more than one serotype can produce similar clinical syndrome. I think I have already explained why this happens. And the same serotype can produce clinically different disease. The most common serotype worldwide is 1 to 7. As of now, the serotypes that are being circulated in the present day scenario are serotype 3 and serotype 7, as far as I know. But serotype 41 is probably also there. But ICMR has to, or maybe some authorities like ICMR has to come with conclusive reports. The usual incubation period usually varies between 5 to 8 days. With this background, let's see a case. Very common scenario in day-to-day practice. These cases are all from ICH. Now, in the first case, sorry, this is a 7-year-old male child, 2 days of fever, 104 degree, red sticky eyes. Now, this picture has been taken when already the stay in the hospital was about 3 to 4 days after admission. This is not the first picture. So initially it was red sticky eyes, a drop of blood near the inner angle of the left eye. That was the complaint from the mother. There was pain in the throat and mild cough, and body ache was there. That was the initial presentation. After 2 or 3 days, this is the presentation in the left eye. So there was hemorrhage, and this hemorrhage we need not to panic, because most of the time these are self-remitting. Although it is quite frightful for the mothers, but this is self-remitting. The fever subsided in 5 days' time, but the cough increased. All of us are facing this. As the fever is subsiding, the cough is increasing, and this cough is not going to respond by any cough mixture or any bronchodilator. Most of the time, this cough is irritant cough, This will irritate the throat, and the child will start coughing. As long as the child is sleeping, the cough will remain little on the lower side. When the child is waking up from bed, the child starts coughing. If the child has allergic background, maybe in the background of bronchial asthma, then you can have overlapping picture of nighttime cough and daytime cough both. Otherwise, mostly it is daytime cough. As the child sleeps, he remains little better. Not exactly better, but little better. So this is pharyngoconjunctival fever, pharyngo and conjunctiva. So most common in children and often occurs at outbreaks. And as we have seen years after years, it occurs mostly in the summer months following summer camps, maybe in the swimming pools or lakes. So affected swimming pools, from there it gets transmitted from one child to another. So pharyngoconjunctival fever, and it consists of benign follicular conjunctivitis, febrile pharyngitis, and cervical adenitis. So these are the classical triad. Mostly species B, the species B and serotype 3 and 7 are implicated, although some others may be responsible too. This may be sometimes pharyngitis, that means the uppermost airway. This may be sometimes associated with the affection of the lower airways. So that is laryngotracheitis, bronchitis, or pneumonia. Usually, some systemic features are there: malaise, headache, some sort of myalgia, and maybe abdominal pain. Now, if you remember, I said the receptor, CAR receptor, that is Coxsackie adenoreceptor. Now, this receptor is present in the abdomen. So that is the reason it might lead to a little bit of abdominal pain or abdominal discomfort, even a little bit of soft stool also. Now, exudative tonsillitis, this is very important. Exudative, mind the term exudative. This particular organism, although it's a virus, may sometimes mimic bacterial tonsillitis, and it is sometimes absolutely indistinguishable from group A streptococcal infection. It can lead to otitis media. However, from the middle ear fluid, adenovirus has not been isolated till date, but it is thought that below 1 year of age, it can cause otitis media. And definitely we know acute bronchiolitis can happen. But this adenovirus, this can cause dry hacking cough. Sometimes it can lead to pertussis-like syndrome. Now another case 2, 1 year, 3 months, male, fever for 3 days, but this time the temperature is pretty high, 105. In fact, I had seen one patient of nearly 107. I don't know whether the thermometer was proper or not, but as per the mother, the temperature was 107. Anyway, so this was well documented, 105 in our institute. So fever for 3 days, 105 degree Fahrenheit, but the cough was, but the cold is not very that much, little bit of cough. There was history of red sticky eyes 3 days back, 3 days prior to the fever. Elder brother in the family with cough. Elder brother is a school-going child with cough and fever for about 7 days back. But the child was not taking liquid, possibly some sort of pain may be there, or maybe because of the viremia. So refusal to take liquids, and the child was admitted due to less urine output and very high fever. So as a routine checkup, we did chest X-ray because little bit of cough was there and respiratory complaint was there, and this was the X-ray. The X-ray is not really very bad. Some streaky opacities. The respiratory rate was not very high. Saturation was getting maintained. Now the total count came to be 16,400 with neutrophilic preponderance of 72%. The CRP was very high, nearly 12 times from the cutoff. The SGPT is high, 112. Now, with this background, it is very difficult to have a child of 1 year or maybe 1.5 years without antibiotic. But this particular child, since there was some history from the family, so this and there's a history of red eyes 3 days back. So, and this is the season of adenovirus that we are facing. So, in this particular case, we tried not to use any antibiotic, and in this case, antibiotic was not given. And respiratory PCR sample was sent. In our institute, we found out to be adenovirus. So we knew it's adenovirus, so it's all clear now. So very easy to make the, I mean, to make the parents understand. So see, you have adenovirus, see the report. So we don't have much to do, just the supportive therapy. So PICU counseling and all. Day 6 of fever. Now the cough increased. Respiratory rate 42. 1 year 3 months child. Respiratory rate was 42. Saturation was maintained at room air at 96%. So after 3 days of admission, so day 6 of fever. So we have again repeated the count because the fever is not coming down, whether we are dealing with something extra or not. Now the total count has almost similar. 16,400 was the previous one. Now it is 16,800. Still neutrophilic preponderance of 68%. CRP is still on the higher side, 70. SGPT has increased further. The other part of the LFT was normal, so I have not put it here. With this picture, another X-ray was done. Now we can see it is viral pneumonia. Bilateral streaky opacities, a little bit of patches. The right border of the heart is little shaggy. So we were in a doubt to start or not to start antibiotic. Still, by some means, we said, okay, it seems to be adenoviral. We have a diagnosis of adenovirus. It can happen in viral pneumonia also. Adenovirus is notorious to cause high CRP. So we still, without antibiotic, on day 7, fever started declining. So happy ending, but the cough persisted. Cough at 1 year, 3 months, if we can't respond, that is very difficult to respond, almost impossible to respond. Now, it is very difficult to make the parents understand that this cough is going to stay. We need to make the parents understand the respiratory rate counting, the other danger signs. But giving some cough suppressant at this age is absolutely a no-no. So it is a viral pneumonia. Now, common strains are, a lot of the strains are there, but the most specific strains are 3, 7, 14, and 21. Remember, nowadays 3 and 7 are in the circulation. They can cause severe and complicated pneumonia. Now, please remember one thing: just mere detection of adenovirus does not prove causal association of pneumonia in all patients, especially in those more than 2 years of age. This is very important. Why? I will tell you in the next slide. As we all know, this pneumonia is definitely very severe
Dr.
in
Uddan,
infants.
you have got just 1 minute left, okay?
Okay. So more severe in infants and maybe associated with some other features. Extrapulmonary complications may happen, like meningoencephalitis. This basically occurs with serotype 7. Myocarditis, that is sometimes the cause of death. I think Prabhash will take up on this. Now, necrotizing bronchitis, and that is the reason why CRP may be very high and may mimic like a bacterial pneumonia. Very high incidence of bronchiectasis and bronchiolitis obliterans in young children. Another child with that particular history, almost in the same age group, but this is at the day 6 of fever. This is the consolidation, right upper lobe consolidation, PCR adenovirus. Now, antibiotic or no antibiotic? I think every one of us will go with the antibiotic. Ceftriaxone started and child improved. As I said, NP swab is representative of the upper airway only. If lobar pneumonia, its better sample is the BAL fluid. So here we can have adenovirus with pneumococcus co-infection, or maybe one followed by the other. For adults, we know it's more or less a mild disease. Epidemic keratoconjunctivitis that we don't see nowadays most of the time. But if it happens, it can last up to 4 weeks, mostly in adults. Acute diarrhea by strain 40 and 41. This can also be as a result of nosocomial infection. Even hemorrhagic cystitis, it can lead to, it's a self-limiting illness, it can lead to red urine, but without fever or hypertension, may be confused with acute glomerulonephritis. Now, this particular entity, acute hepatitis, this was a cascade of, there were a cascade of cases in US and UK especially serotype 41 is implicated for this. But another school of thought was there that adenovirus itself may not cause the acute hepatitis. Adeno-associated virus, that is a type of parvovirus, that may be the causative agent. And that, as a result, WHO has now encouraging, they are now encouraging testing for adenovirus in children with acute unexplained hepatitis. For transplant patient, I am not going to the details. Now, this is the mystery. This is my last slide. This is a case, 3 days fever, severe cough, rash whole body, but starting from the chest and back and subsided in the next 3 days without excoriation. Now, what is the case? We were out of clue. Since there were few of the measles cases in the recent scenario, so we thought of measles. But no coryza, no conjunctivitis, and rash started first on the chest. Then we thought of Roseola infantum, but the age is not appropriate. Is it HLH or MISC or KD, but not fitting into the criteria, and the child is absolutely non-toxic, happy going. Is it mycoplasma, but the lesions are not matching, no erythema multiforme, target lesions are not there. Is it scrap typhus? Again, no lymphadenopathy, no organomegaly, non-sick. Respiratory PCR was sent because of severe cough, and it turned out to be adenovirus. So adenovirus with rash. I didn't know that adenovirus could cause any rash, but rarely it can cause rash. And after literature search, we found out that yes, adenovirus is implicated for rash in the immunosuppressed individual. But this particular child has got no immunosuppression as such. We don't know whether this is responsible for this rash or not, but this was there in the result. So to conclude, it's a non-enveloped double-stranded DNA virus, not at all a new entity, mostly affecting the kids with valid clinical presentation, but we should not panic because mostly these are self-limiting. Few of them may mimic serious bacterial infection, although molecular techniques are there, but that should be preserved for severely ill patients. But sometimes the saga continues, and I think Prabhash and Dipenduda will take up on it. Thank you.
Thank you, Dr. Poddar. There are a lot of questions, but as we have got 5 panelists over here, so we'll try to take all the questions at the end of our session. So our next speaker is Dr. Dibendu Rai Chaudhary. He will speak on investigations and the diagnosis of adenoviral disease. So over to you, Dr. Rai Chaudhary.
Dr. Shapan, before going to Dr. Debindu, I would say a few words. In addition to the Shuman what has said, it is also common in adult also. So any age can be affected, first thing. Second, by 10 years, most children had at least one episode of adenoviral infection. It may be symptomatic, may not be the symptomatic, so asymptomatic, because it has been seen antibody against adenovirus infection 70 to 80% in children, and 50% against the adenovirus 5. And third point I would like to highlight, as you said, type 3 and 7 disseminates and can cause fatal disease in a previously healthy child. What we are telling now, there's a comorbid condition, that's why patient died and all. And another point is very important point, what we face clinically, that's why I want to highlight in this platform. The course is prolonged course, as you said, it may be 3 weeks, even sometimes 6 weeks, slow recovery. In between, there will be precipitancy and recurrence of the disease, because we have a patient, you must have read in newspaper also, some hospital discharged the patient and after 3 days again readmitted and died. So that can happen in adenoviral infection. That must proceed from my side. Now over to Shapan.
Thank you. So Dr. Rai Chaudhary, please start your session.
Thank you, sir. Is it visible? Hello?
Yes.
Yes, visible.
I am
Visible.
and audible also.
Yeah.
Okay. Good evening, everybody. So I will start with a very simple case with whom I am now battling, and from that case I will go to the investigations. This is a boy of 16 years old, as madam has said just now that any age can be affected. He's 16 years old boy and having his board examination. He came to me with fever for day 1, just recently on 27th of last month, and the fever was maximum 103 degree of Fahrenheit. There was a little bit of cough on day 1. I examined and found that pharynx was congested, but chest was clear. I have given only paracetamol 650 milligram SOS and to have steam inhalation only, nothing else. On day 4, the boy revisited my clinic. At that time, his temperature was 104.7 degree Fahrenheit. He was very sick at that time. At that time it was day 4, and the boy was very sick. I have advised for investigations, and this time I increased the dose paracetamol from 650 to 1000 milligram SOS. On day 5, the next day, the investigations came out. It was seen that hemoglobin was normal, 13 gram %, and leukocyte was only 2100. That is, there is leukopenia. Platelets was borderline 1.5 lakh per cubic millimeter. In differential count, it has been seen that only monocyte was increased. Eosinophil was 0, and there was monocytosis. MP was not found, and dual antigen for malaria also negative. So here only there is leukopenia and monocytosis. CRP was 5.4. In reference to the in relation to the reference age, it was 5.5 times, and LFT was almost normal. Typhoid screening was done; it was negative, and dengue was also negative. On the next day, the high-grade fever continued, and the boy became sick, started vomiting, and he's having decreased oral intake. So for that reason, I decided to admit the baby. So the baby get admitted, the boy get admitted. On the next day, the investigations was done. The total count was remained same. It was 2100 in the previous day. Now it is 2060. Hemoglobin was same, but monocyte remains the same. It was 12% in the previous day, and this day also it was 12% only. Eosinophil was same, 0. And platelet was little bit decreased from the previous one. It is 1.12 lakh per cubic millimeter now. So leukopenia and monocytosis remaining the same degree. CRP was 55.2. Here is also the same result. It is 5.5 times of the reference range. In the previous report also, the report was same. RFT was normal. Electrolytes also normal. So and we have done leptospirosis also and scrap typhus. This also became normal, negative. Blood culture was sent, and the report is waiting till now. Urinary was normal, and the chest X-ray was done, and the chest X-ray finding we are seeing here in the right lobe lower zone there is patch. It may be a consolidation. Now coming to the investigations, from this we have a little bit idea that what investigations I have sent and what is the result. Now on the investigations of the current, in the perspective of current scenario, what is the take of the government and the general practitioner and the general pediatrician? What are the investigations should be advised, and what are the rational investigation that should be advised? Recently, the government of West Bengal has declared a guideline. It was published on 21st of February, and in that guideline, they have clearly described what are the investigations that should be done. That is complete hemogram, CRP, COVID-19, malaria, and dengue should be excluded. Scrap typhus, enteric fever, leptospira should be advised when it is appropriate, and other relevant investigations as per the clinical presentation of the patients. Chest X-ray and respiratory viral panel, if facility is available. So in my case, these investigations I have done. Now coming to the respiratory viral panel. So this is the description of the government guideline. Now, whom to go for respiratory viral panel? They have described that if the patient is hospitalized and there is requirement of high oxygen through HFNO or CPAP. If the patient has severe comorbid conditions like congenital heart disease, there may be leukemia, there will be protein energy malnutrition or like such. If there is associated extrapulmonary manifestations like altered sensorium, convulsions, shock, myocardial dysfunction, or acute kidney injury. So in such cases, we can consider for the respiratory viral panel. But if there is a surge of ARI or ILI in the area, at least one time arrangement should be done to check the causative organism is influenza or not. Samples for this purpose may be sent to the nearest government lab having the test facility. So at the outset, at the beginning, if the above criteria are not fulfilled, even then we can send the viral panel to diagnose whether it is due to adenoviral or not. If there is a clustering of cases is noticed in a particular area or community, one-time tests may be required to the referral laboratory. At least 5 good quality nasopharyngeal or oropharyngeal swab samples should be sent. So to have an idea of the causative organism in the community, if there is a large number of cases. Test for COVID-19, preferably RT-PCR, must be done in every admitted case of ARI, ILI, or SARI, because in the prevailing condition, there may be a co-infection with COVID-19 also. So it is mandatory to have COVID-19 test. Now, in this case, I have sent the upper respiratory panel, and it was in the corporate setup. So it was BioFire was done. So what is the result? Result, adenovirus was detected. And what are the other organisms which was tested here? If we go through, we can see there are number of organisms which has been tested here. Coronavirus 229E, coronavirus HKU1, coronavirus NL63, coronavirus OC43. I do not know whether all of us are acquainted with such strain. Severe acute respiratory syndrome coronavirus, that is SARS-CoV-2, which is our concern. Human metapneumovirus, human rhinovirus or enterovirus, influenza A, influenza AH1, influenza AH1N1, influenza AH3, influenza B. And there is Middle East respiratory syndrome coronavirus, that is MERS-CoV, parainfluenza 1, parainfluenza 2, parainfluenza 3, parainfluenza 4, and RSV, respiratory syncytial virus. In the panel, they have checked some bacteria also, that is Bordetella parapertussis, Bordetella pertussis, Chlamydophila pneumoniae, and Mycoplasma pneumoniae. So these are the organisms which are being tested through the upper respiratory panel by BioFire. Now, NICET and NICET from ICMR also do test for respiratory panel, and from our institution, Medical College Kolkata, usually we send the samples, nasopharyngeal samples from the affected children to the NICET, which is situated in the Beleghata ID Hospital campus. So what are the organisms they test? They test influenza A, H1N1, H3N2, influenza B, respiratory syncytial virus, human metapneumovirus, parainfluenza virus, respiratory adenovirus, and rhinovirus. And they also do the COVID-19 virus also. And the test method is RT-PCR. So the viral panel test method is nucleic acid amplification test, and it is polymerase chain reaction, and it is reagent based. And in case of biofire, it is multiplex PCR for detection of upper respiratory pathogen. The sample is same nasopharyngeal swab, and it is mainly cartridge based. So this is the address of NICET ICMR campus where they receive such samples. That is ICMR NICET virus laboratory situated in the ID and BG hospital campus at Beliaghata. So this is the requisition through which we usually send for a media for sending the samples. We ask for the media, that is viral transport media, to ask for the and to send the sample. So this is the viral transport media, and this is the swab stick through which we collect the samples. And these are the few reports of the upper respiratory viral panel from the NICET ICMR. So as I have told earlier, there is few points. The method is nucleic acid amplification test, PCR, and multiplex PCR for detection of upper respiratory pathogen. And the machine is thermocycler for PCR and real-time PCRs. The test time is around 2 to 4 hours. And the cost of the machine, I do not know actually. And price rate of the test, it varies from 6,000 to 24,000. Biofire, they charge 24,000 for one sample of biofire testing. Availability, it is available in the ICMR of Beliaghata campus. It has been recently started in the School of Tropical Medicine, and there are many corporate hospitals and laboratories where the test done. Sample is nasopharyngeal swab and transport through VTM, which is provided by the lab and also by NICET if you want to send it to the NICET. Requisition, there is first you have to requisition for the VTM, and there will be a pro forma they will send, and you have to fill up the pro forma, and with the pro forma you have to submit the samples. And there is serotype testing also, and COVID test, that is NICET does it routinely in every sample, and biofire also they done it. And bacteria, in addition, bacteria test detection is done by biofire, through biofire. This is the thermocycler. This is the PCR machine through which the tests are done. And this is the recent advisory by the government of India, government of West Bengal. And now the take-home message. Clinical diagnosis is possible in most of the cases in this point of time. Blood picture is a valuable clue. Leukopenia, monocytosis, thrombocytopenia, increased CRP is found in most of the cases. Regarding monocytosis, we need few studies also. Severity may be correlated with degree of rise in CRP. It also needs some studies. Co-infection should be excluded in every cases. Chest X-ray detects site and severity of lung involvement. It may be viral-like picture. There may be sometimes necrotizing infection also. Respiratory panel may be done if accessible and affordable, though it does not much contribute to the treatment. Many other investigations may be required in intensive care setup. Government guideline for investigation is very useful in controlling the present scenario. Thank you.
Dr. Divyendu, nice presentation, and you have finished in time. And there are lots of questions. I think one by one we'll answer all those things. And what you said, totally practical, and what we do, what are we doing, and what is practically to be done, and all the information you have given very nicely. There are some tests are there. Other than this, you can do the antibody detection test. You can have an antigen detection, viral isolation. The problem is the viral growth is very slow. It will take 2 weeks time. So, but where you have to know the genomic types and the serotypes, you have to do the viral isolation for the surveillance purpose and for the knowing the epidemiology status of the virus. So there are some investigations are there for the epidemiological survey and some for the diagnostic purposes. Thank you, Dr. Dibendu.
Madam,
over to Swapan.
can I ask something?
Who is there? Please
Ma'am,
identify yourself.
I'm Suman.
You are expert in this. You are
Oh, okay,
expert
okay.
in this field. You can contribute.
Who
No,
is
You can
asking?
contribute.
Oh,
No,
sorry. Who is asking?
actually,
Dr. Suman.
I mean, yes, ma'am. I'm
Yes.
Suman.
Bol.
Suman for that. Ma'am, the problem of NICET is they don't accept samples from the private sector. They
Actually,
take,
I'm interrupting because they are getting so much samples
I
from the
know.
government setup. BC Roy, the only hospital which is sending 50 samples. So even we are
Absolutely.
having problems also.
Yes, sir. Yes, ma'am. That's true. Even when our PCR machine was out of order, they have given us some sort of support, but not totally. But it's not possible for them either. So that's the reason that testing respiratory panel for every patient is not at all required, as Dibenuda said, and I also tried to say. And another thing, what Dibenuda has written, that this leukopenia, monocytosis, thrombocytopenia, undoubtedly is the predominant structure. But many a times we see the other way around also. That is, the counts are high, CRP high. That is also there. And if this structure is there, leukopenia and thrombocytopenia, we are sometimes skeptical about whether it is HLH ensuing or not. We have seen a lot of cases as such. Prabhash will be contributing to it. I think Prabhash is already there, so he will be saying on it, I think.
Yeah, HLH is reported there. It mimics KD. Even I have a patient and then totally like looking like a Kawasaki, but as the criteria are not filled up, so it didn't treat as a Kawasaki. It has been written in the literature that it mimics Kawasaki disease, but it adenovirus can have HLH. Rarely reported HLH. And one thing
monocytosis is little
Actually, we have got a
Monocytosis.
discussion part at the end of the session.
Okay,
So
okay.
there are many of the panelists are waiting for it. Actually, we are running short of time also. So to answer all the question, please confine yourself in the stipulated period time of 20 minutes. Then after you finish, we can take questions one by one and we discuss clearly. So now it's the time to Dr. Prabhash Poshun Giri. He will speak on the complicated adenoviral infection. So your time is 20 minutes, Prabhash. Please share your screen.
Just a minute. Share screen.
In the meantime, I will request our speakers, the panelists who have finished their talk, Dr. Shuman Poddar and
I'm not able to share the screen.
Oh, I think Somnath, please help Dr. Poshun.
Not able to share the screen.
Somnath, are you there?
বাস তুমি দেখো তোমার মাউসটাকে নিচের দিকে করো বা একদম স্ক্রিনের
He knows, I think. He knows. You allow him to do the share this screen. তুমি allow করো.
আমার অ্যালাউ করাই আছে। উপর দিকে নিয়ে যাও, একটা ড্রপ ডাউন স্ক্রিন নামবে, একদম মাথায় নিয়ে যাও টপে।
So I request all the panelists to answer the questions that has been asked in the chat box.
Actually, I have already answered many.
I have seen.
I'm searching if is there anything is left.
একদম নিচে মাউসটাকে নিয়ে যাও বা একদম টপে নিয়ে যাও, যে কোনো একটা জায়গায় তোমার একটা ড্রপ ডাউন নামবে বক্স।
Just a minute, some problem.
Or you can send it to Somnath, he will share.
No drop down is coming. मैं allow করা আছে?
হ্যাঁ হ্যাঁ, এইটা এতক্ষণ
allow তো পাচ্ছি না, তো কোথাও তো কিছু আসছে না।
না হলে নিচে দেখ, নিচেও থাকতে পারে।
নিচে শেয়ার স্ক্রিন আছে গ্রিন কালারে লেখা।
তুমি মাউসটাকে নিয়ে একদম নিচের বটমে নিয়ে গিয়ে একটু এই করো।
না,
ওভার স্ক্রিনের নিচে দেখ, একটা গ্রিন কালারের শেয়ার স্ক্রিন আছে নিচের দিকে, চ্যাটের পরেই আছে।
আমি কি প্যানেলিস্ট লিংকে আছি নাকি অডিয়েন্স লিংকে আছি?
প্যানেলিস্ট
প্যানেলে আছো।
আমি তো করতে পারছি না।
তুই এক কাজ কর না প্রভাস, do one thing, send your to either to me or Somnath da. I think Somnath da will be better.
আমাকে আমাকে পাঠালে আমি এখানে কন্ট্রোল করতে পারবো না, আমি কিছু দেখতেই পাবো না, পুরো স্ক্রিনটাই দেখতে পাবো।
আমাকেও পাঠাতে পারো, স্বপনকেও পাঠাতে পারো, এনিওয়ান।
তুই আমাকে পাঠা।
You can't see the share screen, দেখতে পাচ্ছ না গ্রিন কালারে, দেখা যাচ্ছে না তোমার স্ক্রিনে?
অদ্ভুত একটা, জাস্ট এ মিনিট।
তুমি তাহলে কুইট ইয়ে করে যাও, বেরিয়ে যাও, আবার জয়েন করো।
বেরোনোর তো রাস্তা পাচ্ছি না কোথাও, জাস্ট।
তুমি কি ট্যাবে করছো নাকি?
না, ল্যাপটপে করছি।
ল্যাপটপে করলে
ডান দিকে নিচের কর্নারে আছে লিস্ট।
Swapon, I think another speaker can take over and he will arrange then.
Okay, okay, Prabhas, we are coming.
It's already
Yeah,
9. 1 hour.
We will start your session. Be ready and have a talk with our
ফুল স্ক্রিন
Somnath da.
করো, ফুল স্ক্রিন করো।
Next speaker নিয়ে নাও।
এটা ফুল স্ক্রিন করা নেই, ফুল স্ক্রিন করলেই তোমার চলে আসবে। একদম মাথায় গিয়ে দেখো, ওটাকে ফুল স্ক্রিন করো, ডান দিকের কর্নারের টপেতে ফুল স্ক্রিন যেখানে করে তাহলেই আসবে। এটা তোমার ছোট করা আছে।
So I'll request our next speaker. In the meantime, Prabhas settles. I'll request our next speaker, none other than Professor Joydev Roy.
Thank you all the office bearer of the WAP for inviting me in this session. And also, your sound is not audible.
Yes, 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 yes.
And after the nice talk of Dr. Suman, Dr. Dibendu, I am going to say something that is known to everybody, but that is what important thing. Adenovirus, it is a virus and it has no drug. So you have to give praise on the prevention. Dr. Poddar told us what is the, Dr. Poddar told us how the adenovirus is transmitted. So like that, every viral diseases, the transmission chain has to be break. And
Prabhas,
another thing.
Just a minute, Joydev da. Prabhas, we will start once Joydev da finishes, okay?
Okay.
I'll take less time, 5-10 minutes, because I have to give few talks
Please,
only
Professor
the
Roy, please
prevention.
continue. Please continue.
And we all know the child who are dying by the adenovirus in our state is below 2 years. But when think of the prevention of thing, the below 2 years child is not going to the crowded place, all this thing. So we have to give place on the adult. Isolation of the adult member with fever and the respiratory infections. Specifically, isolate from the children below 2 years. And these 2 years below children has to be isolated from the adult child also. Because adult child were going to the school, because of the exam, they have to go to the school. And another thing, in the school, among the friends, they are sharing their tiffin, all this thing. As Dr. Poddar told us, through the surface contact, through the utensil, this can be pressed. So they have to give the knowledge that you should not share the tiffin with your friends. Another thing is, as it is a respiratory droplet infection, so adult child and adult, they wear the mask because of the respiratory infection. Also, regular hand sanitization and hand washing is the important thing. Like that of COVID, it has to be hand washing, has to be done at least for the 20 seconds. And regular hand sanitization, hand washing is needed. Is you are suffering from the disease or not, because this time is outbreak is going on. Another thing, which I know there is a conjunctivitis occur, it can go through the nose, it can go through the mouth. So without washing the hand, we should not touch the eye, we should not touch the nose, we should not touch the mouth. And another thing, that surface sanitization has to be done in the proper fashion. As the virus is transmitted through the fecal matter, it is a less number of cases is the transmission occurs. So disposal of the sewage is one of the important thing. And definitely the crowded places has to be avoided, and social distancing, as all I know all this time, that has to be given importance. So these are the different preventing strategy we have to take for the prevention of the adenovirus disease. Another thing, Every day in the newspaper and the media, we are getting the child death is going on. So in this thing, one message has to be given to the parent for the prevention of the child death is that they should be aware about the danger signs. Already the government has given what are the danger signs. It is not for the adenovirus, it is for the other viral disease also. If there is a persistent fever for more than 3 to 5 days, if there is a fast breathing, we all know the breathing rate has to be different from the child. If it is a 0 to 2 months age, it is greater than 60 per minute. If 2 months to 12 months, it is greater than 50 per minute. If there is a 1 to 5 years, it is greater than 40 per minute. If there is a 5 years above, it is greater than 30 per minute. Another thing, if there is a respiratory distress, whether the child is suffering from respiratory distress now, the mother can aware, but we can give the message to the parents that if there is an indrawing of the chest, if there is a difficulty in the breathing, if the child is not able to feed, specifically it is told there is a, if there is a reduction of the feed is less than 50%, if there is a needed the oxygen, if the oxygen saturation less than 92% in the room air, if the urine output is less, that is less than 5 times in a day, and Dr. Dibyendu Rai Choudhury told there what is the extra pulmonary manifestation, like there is a alter sensorium, like shock, there is a myocardial infarction, there is acute kidney injury. If these are the present thing, the child has to be go to the hospital early, because when the child go to the hospital, that can lead to the death. Another thing, already Dr. Dibyendu Rai Choudhury and they have told what are the comorbidity factor present in the child. If we are thinking of, although the Dr. Kalpana Dotto told us, even without the comorbid child, the child can be go to the deteriorate form, but mostly if there is a comorbid factor is there, the chance of the severity is more. What are the comorbid factor? That is prematurity, low birth weight, congenital heart disease, if there is a chronic respiratory infection, neurological disabilities, renal disease, malignancy, immunocompromise, leukemia. These are the different comorbidities. If they are present, I think we should give the parents the advice not to wait for the warning sign. If the child is suffering from the cough and cold, all these things, then you have to go early to the hospital. And another point, one thing that is Dr. Sapun Rai put money in the panel, what is the economical and social impact? I here want to emphasize that the economical social impact is like the all the other children's disease. When the child is suffering from a disease, so their parents does not going to the work, and specifically the mother, a good number of mother is the working mother, so they are not able to going to the work. So this has lead to the economic burden, and we are thinking regarding the education system also. When the different parents are asking whether they will send the children to the school or not, if there is a necessary thing, they have to be go to the school. And the parents, one thing again I am giving the trace, you go to the work, but you have to keep the all the precautionary measure. What we have learned from the COVID period, it is the same thing. So again, I am giving the few message, only 3-liners message I am giving regarding this prevention. You take all the prevention which have learned a COVID period, because throughout the year we are telling all these things, you have learned all these things. Second message is, if your child suffering from the other chronic disease, even like that a normal child, you have to take the consultation, but you have to take the early consultation. You should aware about the warning signs. If you keep all this point in your mind, it will help for the prevention of the child for suffering from the adenovirus. Even it will help the parents that the child is not going to the deadly stages, although it was mentioned that different variety or is there, but generally in the common people, we does not know what variety it is, and it is very difficult, although the Shuman Poddar has given some point. These are the findings which is related to that stereotype. These are the findings is related to that stereotype. But generalized way, you have to give on the trace on prevention. We have to trace on the danger signal that will help to child for the survival, and which will help the child for the prevention of disease. Thank you. I am not giving much time, but it is one of the important point. Prevention is better than cure. You have to give trace on this fact. And then I am going to, I am hearing all these things. I think our audience is learning a lot from the adenovirus. Over to Dr. Sopan Rai.
Thank you, Professor Jayadev Rai, for your nice talk and your how to prevent the disease. I have got 3 questions to ask you, as you have
Okay.
told 3 points that you should remember. So, what is should be the policy regarding the schooling? Should we stop sending the children to school? What is the role of the parents for putting on the mask? And whether this is the period of these festivals of the marriage and all that, so should we be refrain from the social activities?
First of all, regarding the school, already I mentioned in my talk that if there is an exam period is going on, so the student has to go. Still now, government has not given any circulation to, although they have in the advocacy they have mentioned, but they have not given any strict circulation. But the school authority, I will be request them in the examination period, they can give maintaining a distance, because it is examination is going on. So in the examination period, they are making a distance. And another thing, if the child is suffering from the cough and cold, if the child is suffering from severe form of the disease, they have to give some allowance, because throughout the year there is a performance in the school there. With that, even they have to refrain from the examination. And day to day school, you have to think of one hope of array is there. We know, although there is a few varieties of adenovirus occur in the summer month, that is swimming pool, all these things. But here the epidemic, what is going on at the time, I think the temperature when it's going steady and going up, so I think disease prevalence will be lower enough. Other panelists and other attending in the audience is there. They can aware that whether the disease prevalence is reducing or not. For the few days, they can refrain from the school if possible. This is the first question answer. The second question, you have to ask what is the awareness of the parents. Already I mentioned in details what is the awareness of the parents. But another thing, again, I am giving traces that the adenovirus is give rise to the severity in the immunocompromised, specifically the children which is below 2 years. They are not going to the crowded places. They are not going to the schools. So it is the parents who are going to the office, you are coming from the outside places. When they come to the house, the child rushes to the parents. But the parents has to be aware that they should not kiss, they should not hug without the proper sanitization, without the proper hand washing. And if the parents is suffering from the cough and cold, they should wear the mask. And regarding the children like the mask, okay, but the children who can able to take the mask, then masking has to be done among these children. I think I have covered all the 3 questions to you.
Yes,
Okay.
thank
Answer
you,
of all the
Dr.
3
Ray.
questions.
Thank you, Professor Ray. You have given a ray of hope that possibly this tool of adenovirus is going to be abated within few weeks.
And yes.
Ajay,
And
Dr.
small children, stool disposal is one of the important thing, although the few numbers. And another
Yes.
question I asked, the whether it is now the temperature is high, still now so much you are saying, because the awareness for the prevention is one of the important factor, because the disease which are present in the community, from that the disease can spread. New case, how much it is coming or not, that has to be taken into account. If the old cases is present, then can spread the disease if you not aware about the prevention.
Dr. Rai, I to add one thing in your prevention.
Okay.
Yes, sir. Yes, sir. Actually, the adenoviral usual course is 3 weeks, 1 to 3 weeks.
Yes.
So if any person is positive and it is diagnosed case of adenovirus, he should divert the students from going to the school at least for 3 weeks. It is yes, long-term persistent. They can shed the virus for long term, as we know from the tonsils and adenoids and from the fecal route. But at least 3 weeks should be the rest for the patient who is suffering from
I am agree with Professor Datta.
Okay, thank you.
Thank you. So our next speaker is Dr. Prabhas Poshun Giri. Dr. Giri will speak on complications of the adenoviral infection. So Dr. Giri, please share your screen.
My
Full
screen is
screen.
visible?
Yeah. Perfectly. You are audible and visible.
Okay. Thank you. Good evening, everybody. So today I'll be going to present on complications of adenoviral disease. We have first encountered the epidemic of adenovirus in 2018 and 19. The epidemic was massive and huge. It started from the November of 2018 and ended on the March last of 2019, and we have continued to see the sequelae and complication of the patients suffer from the disease at that time. After a pause for another couple of years, we are now again seeing this deadly adenoviral disease. The magnitude and of severity of the disease or epidemic of this time is much more than the last time what we encountered. So after the experience of last epidemic, when my residents asked, "Sir, what can adenovirus do?" So I replied in the same way, adenovirus can do everything except pregnancy. So basically, this is a DNA virus. A double-stranded DNA genome is there. 7 species is there. 70 serotypes are there. Among them, most of them are not respiratory-wise. Usually 3, 7, and 4 are mainly causing respiratory diseases. This time we got 4 and 7 isolates from our patients, and there are some recombinant strains, so it's too much deadly. So what are the organ systems that adenovirus can affect? It can affect from the brain to the endocrine system, everything. So I will go into the complication of adenoviral diseases with various cases that we have encountered in the last epidemic. The case 1 is a 3-year-old kid that presented with a fever for last 7 days with UTI symptoms and sore throat with cervical adenopathy. There was bilateral enlarged tonsils with follicles. He developed brushy bucking hoarse cough from the day 7 of illness, started having respiratory distress from afternoon of day 7. We got a distress call from our fellow pediatricians from Kolkata. He told that the patient is having some distress in my clinic. He referred to the patient to ICH. So when he came to our A&E, he had severe stridor, directly shifted to the PICU, and we found the patient was completely choked, is not able to breathe. So next thing first, upper area obstructions, don't upset the kid, and critical obstruction, you have to intubate. The most experienced person in the ICU should intubate the child. At this moment, I was there, I felt that I must be the most experienced to intubate this kid. So try to intubate, and this is the picture taken while intubation. You can see the laryngoscope tube bulb, this is the light illuminations. You can see this whitish membrane and whitish yellow membrane. This is a huge, deep, thick whitish yellow membrane that started from the hard palate, soft palate, uvula, tonsil, going towards the pyriform fossa or larynx inside the vocal cord. And the aperture of the vocal cord in between the vocal cord are very small. You have to take a difficulty to put a type 3 ET tube inside it. So too much membrane all around and very difficult intubation are there. But still we managed to take this photograph within a 5 seconds of time. And this is the picture post-intubation. You can see the complete collapse consolidation of the left lung with compensatory hyperinflation of the right lung. So what may be the cause? The possibly this membrane that went through the larynx, pharynx to the trachea went inside the left bronchus and occluded the left bronchus. So what we can do, that we need to open up this left bronchus. But the ET tube was only 3 sides, so we cannot insinuate a 4.2 internal diameter calimeter of bronchoscope or fiber optic inside the ET tube. So we made some indigenous process. So what we have done, we made the child right side, left side up. We tried to push the tube empirically so that we can reach a bit on the towards the left trachea. You can see this left bronchus. You can see this ET tube is direct to the left bronchus. Then we have given 10 aliquots of 4th lavas to this, and what we got from the lavas, this milky white fluid came out of the lava. This is the 5th fluid that we got. Initial fluid was too much thick. After 10 lavages, this fluid came to be a bit thinner, and ultimately, after 2 days of ventilation, we found this left lung has been opened and this kid has been extubated. So before that, we have sent this lavage for PCR and bacteriology. So all the bacterial things were negative. This lavage revealed plenty of huge peak of adenovirus. So diagnosis is basically an acute adenoviral pharyngitis, tonsillitis, followed by acute laryngotracheobronchitis. Acute febrile pharyngitis is the most common adenoviral infections in school-going children. And it had been a complications of acute febrile pharyngitis of the adenovirus that raised to the membranous laryngotracheobronchitis. I have seen only one case this time. It's a case 2, basically. So 9-month-old kids admitted, not going to details. and developed a persistent diarrhea up to day 14 of illness. So, and the stool adenovirus PCR revealed that adenovirus positive and rotavirus was negative. So this is the adenoviral diarrhea that can persist up to 14 days. So the definition of the persistent diarrhea is telling that if the diarrhea is more than 14 days, then you call it a persistent diarrhea. But unlike a normal viral diarrhea, adenoviral diarrhea can present up to 14 days. This is another case, a 7-month-old baby with severe bronchiolitic illness, put on NIV in PICU, recovered after 4 days. Shifted to ward on day 5, but developed bilious vomiting followed by abdominal distension. You can appreciate the abdominal distension. At that moment, there was a mild cough, no other respiratory symptoms were present. So distress call went to our surgery fellow, and surgery fellow came, he did a PR, and after doing the PR, he got these types of blood mixed secretions in the rectum. So he made the diagnosis. At the same time, we got the straight X-ray abdomen, it revealed multiple air fluid levels suggestive of intestinal obstruction. But on these findings, the diagnosis has been made that it must be some sort of intersusception. The kid has been taken to the emergency OT, laparotomy done, it found to be a ileocolic intersusception. So intersusception is a rare complications of acute adenoviral illness like acute appendicitis. Acute gastroenteritis, the manifestations, hepatitis, you can see, but fulminant hepatic failure is rare. A mesenteric lymphadenitis is there. So you have seen few kids with adenoviral infections that have been recovered but still complaining of pain abdomen, have done a USG, it revealed mesenteric adenitis. But this was a real case of intersusception after adenoviral infection. Among the renal diseases, we have seen recently a case of acute hemorrhagic cystitis. In the last epidemic, we have seen a case of nephritis, but I've never seen a case of orchitis or oculogenital syndrome. One patient with a hemolytic uremic syndrome, we have isolated the adenovirus, but it came out to be a atypical HUS. We do not know whether this is a causative or causation or association. Another kid, this is a 7-month-old kid, presented with a cough and cold for 5 days, fever for 2 days, wheezing for 18 hours, and got nebulizations and oral antibiotics in the emergency department. It's a typical history. 7-month-old kids, bronchiolitic season, cough, cold, fever, wheezing. So diagnosis was made as Walrai or acute bronchiolitic illness. Came to the emergency, 2 sorts of SABA nebulization has been given. Some oral antibiotic has been prescribed by the emergency medical officer. But the story does not end here. So diagnosis is definitely acute bronchiolitic illness. But the kid again came back after 6 hours with severe respiratory distress lethargy and no urine output for the last 8 hours. Directly taken to the PICU. On PICU, we found that the boy was grunting, saturation was only 60% at room air, with a very poor level of plethysmograph. There was central cyanosis, cold, clammy extremities was there, feeble pulse volume. There was a bilateral Krebs query, a muffled heart sound. Liver has been enlarged 5 centimeters below the right costal margin. Initial mean blood pressure was around 40. ABG revealed severe mixed acidosis, pH is 7.1, PCO2 39. Bicarb is 9 and lactate is 8. So this blood gas and clinical context was definitely scary. So what next? ARA, breathing, circulation, disability, patient has been intubated, ventilated, focus done, and chest X-ray revealed a right upper lobe collapse consolidation, a bit cardiomegaly. So a bedside echocardiography revealed a severe myocarditis with a ejection fraction of 18%, with all the chambers has been dilated with a full of IVC. So it's nothing but a case of acute myocarditis. So managing the protocol of acute myocarditis, IVIG has been given, inotrop has been given, ventilatory support has been continued, and BAL PCR revealed adenovirus, again a high peak, extubated after 4 days, but later on developed DCM, but now are doing a bit well, only on furosemide and enoxaparin. This is another patient that came to my OPD in the evening at ICH. The father complained that the kid has a cough, cold, and fever for the last 4 or 5 days, and he came with some swelling around the neck and swelling on the chest. So I got surprised what with the swelling, and then I came to this. You can see the time of crying, swelling has been increased. So when I calculate, typical textbook teaching of palpable crepitations have been there. So it is nothing but a diffuse subcutaneous emphysema. There was no history of trauma, no history of intubations, bag mask, everything. The child came in that way. So immediately he had been taken to the PICU. One blood gas had been done. You can see the PCO2 is 82.9. And then immediately the condition further deteriorated. The kid has been intubated and ventilated. You can see the extent of the subcutaneous emphysema in the kid. It was a very difficult difficult ventilation. Ventilation became a nightmare. And the next blood gas, you can see the pH of 6.684 and almost 250 level of PCO2. I have never seen this much higher level of PCO2 in my entire PICU experience. So it was very difficult to ventilate. Total count was high. CRP was negative. Transaminitis was there. Again, the BAL revealed adenovirus positive and a high peak was there. And this was the next X-ray. You can see there's so much hyperinflations of the both lungs. The diaphragm are almost flattened, air all around air. He had been ventilated for 3 months. There are severe intermittent spasms, 4 episodes of nosocomial infections, tracheostomies, but nothing could help this kid too much. After 1.5 months, when he failed extubation was there, we went for a CT chest. A CT chest revealed severe bronchiectasis, bilateral bronchiectasis. So it's a sequelae of severe adenoviral infections, bronchiectasis. So it's quite well known that the post-infective bronchiolitis obliterans or PIBO is a well-known complications of adenoviral infections. But if this adenoviral inflammations of PIBO continue, it can give rise to bronchiectatic illness. So it was a bilateral bronchiectasis. And this boy had been succumbed after 3 months in the PICU. Another kid, 5 months old, with the history of repeated cough, cold, fever, wheezing for last 2 weeks. You can see the fast chest X-ray. It's an X-ray of day 1 after admission to our hospital. At day 2, you can see how this opacities has been progressed. It is an X-ray on day 4, further progression already intubated. And day 4, day 5, day 6. So this is a fulminant adenoviral pneumonia. The condition deteriorating day by day without any evidence of nosocomial sepsis. The BAL PCR revealed adenovirus. And day 7, ultimately not able to ventilate this kid. This kid revealed, landed in a severe hypoxemia, actually in the need of ECMO. No facility of ECMO at that time in our town as well. So the child succumbed. This is another case of fulminant adenoviral pneumonia. I remember this kid, which the father is very much known to me. This X-ray has been done in the OPD in the day 1 in the morning. Then the kid deteriorated, admitted in the evening. You can see the chest X-ray, further deteriorations in the day 2 morning. Further deteriorations, day 2 afternoon, a huge pneumothorax on the left side, a chest drain lesion, again developed pneumothorax on the right side. And we were not able to give just little decompression on the right side. We were just prepared for giving a chest drain, but the child succumbed. So another fulminant adenoviral pneumonia that has been succumbed within 48 hours of illness. We had no scope to how to deal with this kid. So another patient, so 3 months old kid, to the history of acute bronchiolitic illness, deteriorated and intubated in outside hospital. Transferred here on day 2 of ventilation for further management due to very high ventilator requirement and possible need of high frequency oscillatory ventilation. So initial investigations was almost normal except a bit neutrophilic beta leukocytosis. This is the chest X-ray in our hospital. You can see that a bit hyperventilated lungs with bilateral patchy opacities. Here next extubated on day 5. The extubation was not that much difficult, considered an NIV. But from day 6 of illness, he developed feed intolerance as well as abdominal distension. So first abdominal X-ray was done. You can show that dilated gut loops. But what I could miss in this X-ray, there was a stress of gas under the diaphragm. They were done in the night, and the X-ray was sent to me in the WhatsApp. And at the middle of the night, I also missed this air inside, this below the diaphragm. So I just asked to, okay, put a ILS to be in, do conservative, start some antibiotics like Pipzo, amikacin, metrogil, and just inform a surgical colleague. In the next day morning, another gas X-ray was done. It came to the frank gas under the diaphragm. This is a severe pneumoperitoneum. So when taken to the theater in urgent basis, we can see a ileal perforation was there. There was total 4 perforations inside the ileum. Ileostomy has been done. And then he had been discharged on April of 2019 after 2 months of 2019 after 2 months of hospital stay. So after that, from May 2019 to December 2019, this kid admitted for 9 times for respiratory distress. Ventilated twice, NIV twice, and HHMG 3 times, and ultimately discharged again on 2019 December with a home oxygen dependent. And this is the picture of the short video of the kid after admission. You can see there's a persistent respiratory distress, persistent oxygen requirement. There's a barrel chest, anterior posterior diameter of the chest has been increased. This is nothing but a very typical complication of adenoviral pneumonia or adenoviral bronchiolitis illness, or severe adenoviral lung diseases. That is a bronchiolitis obliteratis. A CT has been done. So any adenoviral pneumonia that needing usually PICU and something beyond HHMNC, what our experience told that more than 90% of them develop ultimately some sorts of PIBO. So this is a typical CT finding of PIBO. You can see the mosaic pattern, mosaic attenuations, high attenuations and low attenuation area. Mosaic pattern is there. So he developed PIBO, and ultimately improved. Now he is off oxygen, but intermittent respiratory distress is there. This kid presented with a history of cough, cold, and fever for the last 8 days, admitted outside. Chest has revealed a right lower lobe pneumonia. So the manager line up conservatively as a community acquired pneumonia, admitted outside nursing home. But the next 2 days, the condition further deteriorated. Started on IV comocycline further by Mero-Vanco, and then the chest was revealed on complete opacification of the right hemithorax. He came to ICH on the day 9 of fever on 22nd of April, almost gasping. There was severe mixed acidosis, hypoxic, intubated, ventilated, chest X-ray, complete right hemithorax has been opacified. Focus, right-sided massive pleural effusions, chest drain has been given, a big aeration had been seen. There's a picture of the kit after intubations and chest drain. So total count was almost normal. CRP was just marginally elevated, BAL adenoviral positive, and no other organism had been found out, and pleural fluid was exudative. Is a picture followed by that ultimately improved, extubated, and on sudden morning after extubation, second developed increased respiratory distress. So you can see a pneumothorax in the right lung. So again, a chest drain has been placed. So necrotizing pneumonia is a complication of adenoviral disease, and adenoviral disease is notorious to cause necrotizing pneumonia like H1N1. Like staphylococcal pneumonia, this necrotizing pneumonia is also very much troublesome in management. We have seen quite a few cases of necrotizing pneumonia without any evidence of staph or Klebsiella involvement with pure adenoviral lung diseases. This is another case of necrotizing pneumonia, and you can see the CT scan revealed some pneumatocyl inside the lung parenchyma. He was admitted for 45 days and ultimately discharged, but persistent wheezing and intermittent respiratory distress for last 6 months, not actually last 6 months, for the last 2 years, 6 months. So adenoviral pneumonia is the second most common virus, viral pneumonia. Severe and fatal illness is noticed in under antibodies. Viral pneumonia may present with features more typical of bacterial infiltrate, high fever, and parapneumonic effusions. Up to 60% of patients having severe sequelae like persistent wheezing, bronchiolitis obliterans, bronchiectasis, and unilateral hyperlucent lung or McLeod syndrome. So what is our experience of this fatal adenoviral pneumonia from December 2018 or April 29? We got total confirmed adenovirus cases in 96, only PCR positive. Admitted in PICU was 33. And you can see the age group between 6 months to 12 months were more fatal. Among the 33, these were the main patients. So respiratory support needed almost 90% of patients. Most of them needed ultimately invasive ventilations. And there was a huge mortality of around almost 30% of that cases last year. Fortunately, this year mortality is still low, but still 3 or 4 severe adenoviral diseases are fighting in the ventilator. Don't know what will happen in the next couple of days. So those who are recurrent symptoms after 6 to 8 weeks of the illness, we have done the HRCT. 2 revealed bronchiectasis. Most of them revealed typical features of PIBO. We have published this case in Critical Care Pediatrics. It's an epidemiology clinical presentation and respiratory sequelae of severe adenoviral pneumonia in children admitted in a tertiary care pediatric intensive care unit from Eastern India. A single substance center observational study. So just 5 minutes more. So am I audible?
Yeah.
This 10 months old kid, cough cold for 4 days, fever for 3 days. Respiratory distress for 1 day, Walrai admitted in the ward. Walrai have been improved but developed 3 episodes of GTCS in the pediatric ward. Shifted to PICU. When PICU developed a refractory, not actually refractory, he developed basically super refractory status epilepticus, intubated 3 AEDs, Midas infusions, short-term infusions of ketamine. CSF revealed features such as aseptic meningitis. MRI brain revealed few hypointense lesions here and there in the cerebellum as well as the brain parenchyma, in the midbrain and cerebellum, in the parietal lobes, and CSF and respiratory viral PCR both were positive for adenovirus. Recovered gradually, had neurosequelae. So this is the first case of proof adenoviral encephalitis that we have seen, because both the CSF and respiratory revealed adenovirus. Another patient, severe adenoviral bronchopneumonia, detected was adenoviral. On ventilator, improved, but after 5 days, developed new onset fever spikes. There was hepatosplenomegaly, hypotension, increased ventilatory settings, capillary leak, prolonged bleeding from peak site. So possibly diagnosis of a secondary nosocomial sepsis with DIC had been made. The blood count, you can see from day 1 to day 3, there was falling hemoglobin, falling total count, falling platelet, rising CRP, and rising transaminitis. And so in ICH, we definitely think about the HLH, not only ICH, all over the world. Now we are there thinking about hyperferrotememic sepsis or HLH. The ferritin revealed 54,000, LDH was high, triglyceride marginally high of the HLH. They have been put on IV pulse, methylprednisolone, IVIG, but ultimately succumbed. So HLH is a known complications of adenoviral diseases. We got lots of cases of HLH in the last year or this year as well. If you put on HLH 2004 criteria, but what I personally feel that HLH 2004 criteria is over diluted criteria. If you put this criteria in all the PICU patients will fulfill the HLH 2004 criteria, but all will not need immunotherapy. And in PICU, as the chances of sepsis is more, I'm very much scared to give very high dose of steroids. In our experience, a low dose of steroid, only 1 or 2 doses, 1 or 2 days. Most of the time, this HLH or hyperferrotememic sepsis or cytokine storm, whatever you tell, most of them had been recovered. And those who needed pulse methylprednisolone almost had a 100% mortality. The last case, this 9-month-old boy admitted in ICH on 24th of March 2019, intubated from a private hospital due to increasing respiratory distress after remaining admitted in 2 government hospitals with history of cough, cold, respiratory distress, and fever for 7 days. The first test X-ray, not that much remarkable. There was persistent wheezing after extubations. The child was discharged with MDI with levosalbutamol, ipraben, and Budecort, along with multivitamin and Comoxiclav. But only after 2 days, the child has again admitted for severe respiratory distress and fever for 1 day, 7th April 2019. On admission, child has severe distress with suprasternal or subcostal retractions, needed HHMSC support. All sorts of anti-wheeze therapies have been given. Due to persistent wheezing beyond 4 to 6 weeks of the illness, HHRHS has been done on 12th April 2019. It revealed the features of PIBO. So, had a window condition on April 5, detonated in April, put on HHMS in April 7, put on NIV on June, intubated 2nd time in July, intubated 3rd time in August, 4th time intubation was October, then put on HHMS from October 2019 to till before the lockdown March 2020. Was continuously on HHFNC with from April to December. In the meantime, only 48 hours off of HHFNC. In the meantime, he was deteriorated on HHFNC, put on NIV or intubated. With a picture of the kid, he spent almost a whole year in the ICHP ICU. We celebrated his birthday. You can see the patient is on HHFNC. And ultimately, what we found that even after 9 months of intensive hospital stay, he was total HHFNC dependent. So we have sent the kid with a home HHFNC. This is the first kid in India who had been sent home with HHFNC. There was report that home ventilation on bypass this first kid because the HHFNC makers told that they have never installed a HHFNC in a home at that moment of time. In 2020, just 3 days before the lockdown, he had been sent to home. We have published this case as a case of post-adenoviral bronchiectasis being managed at home with humidified hypronasal cannula. This kid, interestingly, on 8 weeks of CT scan revealed features of bronchiolitis obliterans. At 4 months, the features were suggestive of bronchiectasis. So, it's a picture of the boy, Ankit, in the last puja. He was doing well. He received many obstacles in the life. Thank you for this complication. Just before ending, now just 1 hour ago, we got a kid referred from a hospital, admitted just 1 hour ago in ICH. I'm sharing the chest X-ray. This is the chest X-ray. We can see there's an extensive air leak. Patient is intubated. Again, the pH is 6.9, severe acidosis. And this is the known case of adenovirus. So how can this kit can be salvaged? Without ECMO, it is impossible to make this still salvageable. Even with the full bagging, saturation is only 60%. So this is impossible to make this cell survive without any ECMO support. Thank you.
Thank you, Dr. Giri, for your excellent cases and how you managed Possibly we have to answer few of the questions in the chat box. Please go on answering those. And before the last speaker, Dr. Professor Mihir Sarkar, we have discussed about the what is adenovirus, what is the normal clinical presentation, how to investigate and diagnose, and then we have gone through these complications of the adenoviral infections. And Professor Joydebra has also enlightened us with the social implication and prevention strategy. Now I would request Professor Mihir Sarkar to discuss on the government policy and the guideline in this scenario of this adenoviral toll in this part of this country. So over to you, Professor Mihir Sarkar.
Thank you, Dr. Shapon Rai. Actually, that's very nice discussion throughout the last 1.5 hours on the adenovirus, but I think many of you will be scared after the Provost presentation, all the complications. But still, as a whole, Shapondas asked me to tell the government policy and guidelines, though I am not till the government to say there's about the government policy, but acting closely or the working closely with the last few weeks. So what is the main highlights that I just want to say? And so actually we have a very perception based on the seeing the cases, severe cases, and which are being referred to the tertiary care hospitals, and the media coverage and the social media news and the news media coverage. Already there is panic button. But is it really a perception, or it is still a very high number of cases that actually happening, and also the death is very high? So if you look at the data, our common perception is that we are seeing the very high number of cases usual than previous year or the last 2 years. Even we had an adenovirus in huge number of cases in 2018-19, but we are getting more cases than 2018-19. Yes, that is there. But the death rate is high, so that is again a perception, because patients are being admitted even in the subdivision and district hospitals. They are getting discharged, but the death rate and the reported death are not so high there. So patients who are very critically ill and sick, and many of the already there is discussions that the patient who are getting second time or third time attack are they are becoming very severe. So these are the patients who are actually being referred from the district hospitals and very sick stage and all complications. So these are the patients that have a mortality or very bad outcome. So that the high death rate that is being projected by the media at the present time could be a perception, not the fact. So points just I want to highlight is the preventive strategy, how we can take. Already Dr. Joydeep Rai has told in details. I'm not going to tell in details, but yes, the pediatricians should take the pivotal role. Already Joydeep sir has told, but again, the pediatricians, we are in the social media, in YouTube, there are many videos on the pediatricians on the how we can care the children with the adenovirus or recent viral infections. Is this a very good initiative from the individual part or the but we must be very sensitive. That's one thing I want to highlight, that whenever we are giving any comment to the media, we must be very sensible to that, our word should not press any panic button. So that is our role as a pediatrician. Other preventive strategies that Dr. Joydeep Roy has told in details. I'm not going in details. Then against the testing. Testing is an important part, and the many pediatricians from the peripheries, they're asking that, and also in Calcutta, there is not wide availability of this testing. So they are scared that we are not able to test. So how can we differentiate between the adenovirus or other virus or the bacterial infection? So again, the government policy that has been circulated, and already Dr. Dipendu Rai Chaudhuri has shown that it is not required to test for all children. The children who are on high oxygen therapy or requiring increasing oxygen therapy, at least on HFNO or the CPAP, go for testing and for them. So it is not that you required to test for all the children. So do not panic of the testing. use your clinical acumen and judgment regarding the start of antibiotic. Yes, you are already a pediatricians. I think that your clinical acumen and judgment will be better if you want to start antibiotic or not based on the viral panel, because sometimes even there may be the secondary infection. If the fever is progressing more than 5 days, patient is toxic, if there is lobar pneumonia, yes, we are getting even in adeno with the lobar pneumonia and all sorts of pictures, but yes, your clinical judgment is final. You can take a call on that. Then triaging on a sick patient, that is very important. Whenever you are going for not only in the emergency department, but also in OPD, it is very important, because the OPD, there is a 200, 300, 400 patients, but a sick patient is in a queue of 200 or after a 50 patients. So your nursing staff and the support staff in the OPD should be trained how to rapidly pick up in a child who has been very high grade fever, who is sick, who has respiratory distress, or who is very drowsy, not looking well. So pick these patients very quickly and give them and tell the doctors to check them very early. Otherwise, it will maybe become late in the OPD as well. And also in the ER, mostly from the district hospital, in the tertiary care hospital, it may be more streamlined, but in the also the district hospitals or in the subdivision hospitals or in a small nursing homes, the triaging is very important. Which patients are moderately sick, which are very severe, and which has very imminent cardiac or respiratory failure. So you have to pick up these patients very early and have to triage. So that how you can reduce the late severity of the disease, and early referral can be done or timely intervention can be done. So danger signs and hospitalization signs from the ER or from the OPD practice already given in the government guideline, and you are all, I think, you know, and the common practice that we do in normal ERI, that is being there. So it is nothing new, but practice it in your OPD and your private clinic. So when to hospitalize the child, and the danger signs you have to explain to the parents when they should come back to the hospital, to the doctor or to the hospital for getting admission. So that is very important. Then the early warning score that you can use in the trials in your OPD or in your private clinic as well, or in the emergency. So patients who are having these red areas, that is the patient with cardiovascular collapse, or the patient has severe respiratory distress or impending respiratory failure, altered sensorium, these patients should need to shift to an adequate near to the HDU or PICU care. And many pediatricians from the district or subdivision hospitals, they ask they don't have the PICU, how they can manage this patient. So if they don't have the PICU, they have the cardiac adult CCU. I think most of the district hospital and subdivision cardiac ICU, just stabilize the patient there, utilize the resource there and stabilize the patient. And before, do not send the patient in that stage. The patient will crash in there will be cardiac arrest in between the transport. So stabilize the patient, then again send the patient to a facility where the PICU is available. So triaging is very important. So, and also who are very in your ERI ward, use this and the monitoring score for and educate your nursing staffs how to monitor. If the patient with a moderate disease who are going to severe disease, you need to escalate your respiratory therapy. So that is when you need to escalate your respiratory therapy. That the criteria should be well will be trained that your nursing staffs, your other support staff, or your postgraduates, or your MT critical care, or the technologists who are there monitoring everyone in your ward or in your ICU or in your emergency. So educate them what is early warning score, what are the things you have to monitor when the patient is deteriorating, and you have to call for the early intervention in this patient. So that is very important. So what are the factors that can lead to severe adenovirus pneumonia? Thus, a few studies have shown that the risk factors. So I'm not going to details. So one of the risk factor, yes, a second or third attack of the illness that has been already discussed, and few laboratory parameters like the high CRP that is already being discussed in the in this CME. There's a high CRP or high LDH and high procalcitonin has been assigned as more than 1.5 of procalcitonin or CRP more than 20 in patients with severe adenovirus pneumonia. They are core risk factor for going to mechanical ventilation or mortality. So it is whenever you are doing this test and if you find these pictures in your lab findings along with your clinical findings, whatever you are following, so you can be cautious that this patient might going to be in a serious, severe adenoviral pneumonia, even going to mechanical ventilation. So you have to be very cautious and for them, seek for the early ICU care or early age-due type care. Ensure adequate and continuing support during transport that I have already told. So whenever you are transferring a patient for your higher center, maybe a private hospital or maybe government hospital, ensure that the patient is well supported, life support, if the patient required life support that has been given to the patient, then transport to the patient. Otherwise, the patient will crash in between and will get the very bad outcome. Be ready with training, logistics, and surveillance. That is very important. So training that we have arranged one today. So this training should be continuing in your small scale, in your hospital or in your OPD or in your private hospital, wherever or in your nursing home. So the training of the nursing staff, other support staff, junior doctors are very important. They have to be ready with the logistics, the respiratory support you require, whatever the respiratory support, it is the only oxygen if it is you have only oxygen. So be ready with the nasal prong adequate number, with the oxygen mask or even the NRBM mask. So that will be important. So not only that, you ready with your monitoring kit, what are the things you have to monitor, when you need to transfer the patient, where you need to escalate the therapy. That is very important. If you have a facility for HFNC or giving the patient or non-invasive ventilation or mechanical ventilation, check with the logistics if you have all logistics ready with you or not, because you will get the many patients who are coming in being transferred from the peripheral centers. If you are not able to ready with the logistics, then in the middle of the night you will be in problem. Then surveillance is being important. So keep your data. Prabhas has shown the data keeping. So now the government has made a compulsory to send the data. So it is very important to continuous surveillance. So what is actually going on? So it is the death rate is increasing, is the cases are increasing still, or we need to adopt any other further strategy, or it is going down, where already the peak, we have reached the peak and it is now going down. For this data, the surveillance and the data reporting is very important. So with this, I will conclude here. If you have any question, you can ask.
Thank you, Dr. Mihir Sarkar. Actually, as you have sensitized all our members that don't press the panic button. Professor Joydev Rai told there is a ray of hope that as with the advent of the summer, possibly this toll is going to go away. So with this promise and some positive aspect, let us fight this disease. Possibly we can save more and more lives. So now it is question and answer session is open. So I will request Professor Kalpana Datta to conduct this session of the question answering.
Okay. Before telling anything, I would like to add few words and on the vaccine aspect, because someone has asked about the vaccine. So there is a vaccine, live adenovirus vaccine. This vaccine is elicited immunity to adeno serotype 4 and 7. And it is available as a gelatin-coated capsule of a live virus and given orally. Okay. Am I audible?
Yes, yes.
Okay. And the coating helps in the virus to pass into the stomach, and as Dr. Roy already said that, and Dr. Giri also said, there is an infection in the gut. So intestine, that is, there is a immunity against that adenovirus. So this capsule coats, as there is a coating, it bypasses the other esophagus and stomach and infects the intestine, where the immune response is raised and is highly effective. And this is used by, but not available in India. It is used by United States in the military camp. There is an outbreak in 4 and 7 variety in 1971. And they've used it from 1971 to 1999. And again, 2011, there is an outbreak. There are lots of outbreaks in different countries. I have already posted in chat box. But only the United States have used this vaccine. And it's not used for the regular purpose. It's not used for the adenoviral infection in the children, which is not available in India. This much I would say about the vaccine, because Dr. Patra has asked many questions. about the vaccine.
One thing I want to mention regarding this vaccine, as Professor Dotto told you, it is covering the 2 serotypes.
Ah.
So many serotypes is Suman Poddar told to us.
There
So
are
regarding
8.
this,
Yes, yes.
Suman
continue.
told
But
88
this
serotypes.
two
He told
serotypes
about
only
the
associated with a severe disease, type 4 and
Now-
type 7.
Yes, now 104 serotypes is there. I've already, yeah,
yes, more
Yeah,
than
I've-
100 serotype is there.
yeah, I've
But
already.
one thing,
Uh,
as all the serotype, it is not covered by this thing. It is not used in general populations. It is used in the military corps. Trial is not given in the general population. And after that 99, why the vaccine is taken off from the market? Because of the financial reason also. When the vaccine is, it will be stable in the market. If it is a pandemic, if the number of cases in the different part, although we are getting this adenovirus, this is in different parts of this country. We are getting from Delhi, we are getting from the Haryana, we are getting from Tamil Nadu, but so much peak is not like that of in West Bengal. So in think of vaccine, the number of cases will be there. It will cover the more serotype. The trial has to be given. Why in coronavirus so much of split vaccine we get? Because it was pandemic. So much vaccine is used. So when you think of the vaccinology, another thing, what the child is dying in our state, we have to think, we have to analyze this properly. What serotype disease is giving rise to the severe varieties of disease? Again, I am giving emphasis that the adenovirus is a benign virus. Although they are taking the life, although the ovas is given you the good amount of the rare type of cases and severity, but all the we are the hearing this message from this audience. Don't be panic. Give the precaution. Give the message to them regarding the vaccination. Till now, no vaccine is available. But if this sorts of outbreak is going on different state and different country, I think we can think about the vaccines. And regarding this vaccine, the genetic sequencing is one of the important factor, and serotyping is one of the important factor. Specifically, we are suffering from the severe types of disease.
yes.
That much of thing I want to give to the audience.
Yeah, actually,
I
there are. Yes, sir, continue.
Because if vaccine is one of the important aspect of the prevention, might not be such prevention. So vaccine is one of the important factors. But at this present moment, not so much space is going on for this disease, which I have mentioned already.
Okay. So, and actually there are different types and serotypes and types of the species of the adenovirus. And someone asked whether any immunity. No, actually what happens, even the mother, that the newborns gets antibodies from the mother, it usually disappears by 2 to 3 weeks, and even after birth also. So we
Yes,
are getting, even we have a few cases in our SNCU also, adenopositive, because it won't, antibody won't last longer even after, just after the birth. Second point, yes, and and there are different methods, as someone said, some advances was going on or not. The advances are going on because of, I have already written in the answers chat box that there are different methods of microscopy and atomic force microscopy, and also there we are getting more and more varieties and types of adenovirus. But there's no research regarding the management or the vaccines itself. No, I don't have any data that the vaccine trial is going on, or any thought of vaccinations for the masses. This is not there. So
Yes.
only in that is the capsule is there, and it is used in outbreak in military setup in United States. That's all only about the vaccine.
Okay.
What
Because
is the
it
duration?
doesn't give any cross-protective immunity. That is the reason.
Yes, there's no
Yes,
question.
yes.
And it's written what is the duration of immunity post-infection, even if serotype is specific. Next question is, what is the duration of immunity post-infection, even if it is serotype specific? Any panelist?
I think
Not exactly known, but it is
Yes.
probably, it is for months to years. It is serotype specific, and when it, specifically in adults, probably that is the reason the adults are not suffering more for this particular illness, whereas due to the absence of this neutralizing antibodies in the kids, they are suffering more. Probably that is the reason, but exactly for how long, that we don't know.
It is individual, it's not only all the children, because there's an exacerbation, a reinfection also with the same types.
Absolutely.
Effect on newborn, someone has written effect on newborn if the mother had adenoviral infection during pregnancy. Any answer from any panelist? No. Actually,
No.
adenoviral, yes, adenoviral infections, it will go off and there will be antibody formation that will be placental transportation to the baby, but it will disappear soon. So babies are prone to have an infection again.
I think he's asking whether any teratogenicity
No,
is
no,
written.
yet
No,
not
no,
yet.
Not yet.
No, not regarding teratogenesis. I think question is answer whether it will give any protection or not.
No protection, because the antibody disappears just after birth, 2 days after birth. And we have many cases of adenovirus with below 1 month in our hospital.
But in fact, if the
yes,
cough
sir.
if the cough is really bothering that particular mother, even the pregnancy in the early stage may get aborted. That can be happen.
Yes. Like
Another question they have asked regarding this, whether the steam inhalation should be given, because when the virus in the upper respiratory tract, you have given the steam inhalation, and it will be helpful or harmful. That was one question was asked by any of the, I think, from the attending. And that one question
There are a lot of questions about the leukocytosis, Professor.
No,
Yes,
it is already answered.
Still
It is
they are
already answered.
yeah,
it is
but
already
still they are
answered.
asking. So
Yeah, I think
one-liner from you.
I think.
Sir, can I tell that?
Yeah, anyone. Okay.
So
Shogota,
actually what happened, I am dealing less than 3 months baby. And most of the adenovirus cases, I am getting leukocytosis, not a single case of leukopenia. Even the 65,000, 70,000
most of the cases.
WBC
Yeah,
count
that is.
with ARDS presentation, I am getting. Last patient I got the day 9 of life. Patient had 65,000 WBC count, and that get to the adenovirus positive, and it has at a whiteout lung, and ultimately we had to all the HLS features that's we got. So most of the newborn is developing ARDS, and they are getting they are getting this procalcitonin high as well as all the HLS features. So initially we are losing lots of newborn. So subsequently I was asking the PICU people. So they told that you can start with methylprednisolone actually. So it is not guidelines is there in newborn, but subsequently I started methylprednisolone using in the newborns with ARDS, those who it is very difficult. And subsequently, yes. And last 2 weeks, not a single cases expired on newborn.
Okay,
So
thank you.
Kovas is raised his hand.
I think.
So I don't know. Methylprednisolone using methylprednisolone is dangerous because I have to need the follow-up also. What is the brain neurodevelopment?
Okay. Dipendu.
Yes. Prabhas, please. Prabhas, then
one by one, please.
So I want to ask Mihir, what is experience about the severe adenoviral diseases less than 6 months age? Because we have seen the maximum crowding of the cases between 6 months to 12 months.
Yes.
There are few cases beyond 1 year, but less than 6 months, I have hardly seen any severe adenoviral diseases.
We have seen from 3 months. We have seen from 3 months.
Yes, we have seen.
Yes, so
we have seen 2 months. 2 months.
Mainly from 3 months to 1 year. So that is the age group we are getting. Not the newborn. There are Sogotoda mentioned in also in our hospital. There are 3-4 newborns which are severe viral pneumonia. 2 had adeno and 2 had RSV. And so mainly 3 months to 1 year. And one thing I want to highlight that many of the time it is not the adenoviremia, it is the inflammation, ongoing inflammation that is causing the more harm. And the ongoing inflammation in the host immune response that is ultimately leading to your necrotizing pneumonia and the all sorts of lung injury, epithelial injury, and sometimes, as Professor mentioned, few cases that is abnormal repair, and that is leading to bronchiolitis obliterans and all sorts of respiratory problem for a prolonged time in few of the kids. So it is the we have not found this except besides the comorbidity. Yes, always that is their comorbidity. Even with COVID, we got the comorbidity, but otherwise the few studies have only one or two have studies have shown which are going to very severe adenoviral pneumonia. There is no as such very great clinical marker or any laboratory marker. Just I have shown that the CRP more than 20, LDH, Procal they have shown, but yes, that is also applicable for other viruses or the other inflammatory stages also. So there is as such no clinical marker. So it may be the genetic pattern of the few patients which are getting the a dysregulated immune response to this viremic phase that is going on persistently, and that is causing the damage. So that may be the cause.
Okay, thank you, Dr. Mehir. I think Suman is
Actually, madam, that is the reason why this CRP and Procal are high. Because of the cytokine storm and the tissue damage.
Yes, yes, this is the explanation.
Someone has asked for it.
Controversial thing is about the use of steroid. Nobody knows.
Yeah,
But what is the opinion of the house about the use of the cidofovir?
I'll answer about the cidofovir. Just before that, there's a question. I think that Dr. Suman is the right person to answer. I'm reading the question. What specific mechanism does adeno use to evade the host immune response? He has nicely explained. But again, the question: how might
already Suman is described in his presentation.
Yeah. How might this knowledge inform the development of more effective antiviral therapies? So, Suman, just highlight few lines only, that internalization and that fibers and that knob and that all those icosahedral and all those. Just a few words, nothing in detail.
Actually, the virus gets attached by the fiber and then gets incorporated within the cell with the help of the pentons. The hexons gets dispersed, and then the nucleic acid translocation, replication, all this happens. There are certain regulators in the early phase of this, cell cycle. During this phase, there are certain proteins, early phase proteins like E1A, like E3. There are certain names of them, which actually utilizes the host machinery and stops the host metabolism to evade. These two mechanisms together helps on one hand to replicate the virus, and on the other hand, evades the host cell to produce something to kill this particular organism. That is, in one liner, this can be said. The early phase proteins. These are the things.
Thank you, Suman. The other question, cidofovir.
Yes, that is in our institute.
Please.
Yeah, I want to mention Dr. Shogoto Choudhury. So, in your cases regarding leukocytosis, have you excluded the secondary infection due to other bacteriological causes? That is also very important, because we have seen there is co-infection along with this viral infection also.
No, sorry, bacterial infections are very rare. We are not getting, because the blood culture also negative, and we are actually we gave baseline antibiotic piperacillin tazobactam only, and we continued with that drug only. We didn't hype that drug therapy also.
And those
only we added the steroid ultimately to save the baby subsequently. But previously, many babies we lost. But last 2 weeks, only we add the methylprednisolone. But after consulting with the PICU people, and now we are getting better result. I don't know what is that. And leukocytosis, because newborn leukocytosis is not the features. Newborn leukopenia is the sepsis marker. But we are getting lots of cases of leukocytosis, and when we are getting leukocytosis, we are thinking of this, and we are getting all the cases, even the procalcitonin high also. These are also, and two cases I have given.
Last question to all the panelists. Is cup sufficient for this COVID patient?
Dr. Chopin, please let me answer the cidofovir. It is already person.
Okay. Yeah. We have used in an institution, but I want to hear from the others.
Sir, there is no indication in immunocompetent patients. Cidofovir is a viral DNA polymerase inhibitor. Is used to treat adenoviral infection in a selected population of immunocompromised. Not recommended in immunocompetent. It's boldly written, not recommended in an immunocompetent patient, and it has a limited viral activity. Moreover, it is a very nephrotoxic. It should not be
used. The drug that can eliminate the viremia for immunocompromised. Why this drug should not able to eliminate the viremia from a disseminated disease from in a immunocompetent?
No, it's not.
We are using meropenem, vancomycin, acyclovir in immunocompromised. We're also using.
No. Because of the
disease.
nephrotoxicity, it is not practically, it is unlimited
Yes,
viral
we
activity,
want
not
to
as a
know
strong
what
viral
is
activity.
This
First
necrotoxicity.
Mihir, then
Yes, so
Sumon.
there
First
are
Mihir, then
proponents
Sumon.
for Cidofovir, Prabhas, Somnath, and I think in Apollo they have also used the Cidofovir. That's the two things I have to mention. That that's the one reason the Prabhas has mentioned that the drug which is used in immunocompromise also act as immunocompetent. Yes,
Nephrotoxicity.
Yes, nephrotoxicity is there because adenovirus, I don't think they have much causes the much endemicity and much severe disease till of now in Western countries. That's why I think Cidofovir has not used or studied in immunocompetent children as of. So if it is there and it is increasing, I think I sure there will be studies. And one thing is that the patients who are getting but it should be used in the early phase when the viremia is there. So if the patient who was just on from the oxygen to HFNO or from the just HFNO to going to the BiPAP, just requiring, so in that stage, if you can use, then it will be effective. Otherwise, in a government setup, we are getting the patient who are second time or third time having deteriorating and coming. So I think in this population, already the viremic is over. So using the Cidofovir, I don't think will be helpful in this patient.
One thing, Mirza, it's very much essential to document the quantitative viremia in each and every patient before using Cidofovir. But the main problem is that we cannot quantify the viremia. We cannot get the viral load. Like in CMV, we can get the viral load, and depending upon that, we can give ganciclovir. But in Cidofovir, we are not getting the viral load. That is the main problem.
Moreover,
but I think that if we can get the viral load and the patient is having severe disease, we must use it.
Yes, because the adenoviral positivity may be due to the last that we got the COVID. It may be the killed virus already not viable.
Virus. The latest guideline I am talking about 2021. HHS publication 2021. You go through, there is it's written, it is not recommended in immunocompetent patients. Thank you.
Not recommended because it's not been studied. We can do a study.
Yes.
On the study mode, you can do
the patient.
One by one, please. One by one, please. Please raise your hand. Please raise your hand and then answer.
So now, at the present moment, you have to not to use in immunocompetent patient. It needed study, but immunocompromised patient, it can be used. That is the recommendation. But OAS is using, getting good result. It needed more study regarding this thing. I think so.
Sumon?
Sir, actually, my view is when the child is already dying, we should not stick to what we have in my hand. We should not be leaving any page unturned. Very recently, we had a patient, Prabhash is dealing with the patient still now. The patient was admitted in ICH and the child was absolutely in a really very bad shape, absolutely white out lung. After 7 to 10 days of ventilation, absolutely the child was in a mess. Then this was last thing that we could do is to start this Cidofovir, and after 48 hours of using it, Prabhash knows better than me, the lungs started improvement. Now the child is at least surviving, but probably the child will be landing up into bronchiectasis or maybe bronchiolitis obliterans, but at least the child will be surviving. At that point of time, the child was absolutely dying. When the child is dying, if we have some amenities, why don't we try it after proper counseling with the patient?
That is my one head-to-head counseling, basically.
Absolutely. I second you, Prabhash.
Yes. So whenever, as you understand from the COVID, the use of remdesivir is always, we have told that the patient who has ideal time should be between 3 to 5 days or maximum to 7 days when the viremic phase is there. So at a patient who is on 10 days or 12 days on ventilator, at that time, the using a Cidofovir and the patient is getting better within a span of 24 or 48 hours. So it will be difficult to say this only the Cidofovir is doing. So because if the patient is still having the high virus load at that time, it's difficult to ascertain at that time, with already the 10-12 days on the ventilator. So yes, it is, if you're using, and what I think better to gather the data when you have used, what was the markers, inflammatory markers at that time, and then the analysis will be, and if you publish that result, that will be helpful. Otherwise, one just using 2-3 patient and getting an odd result out of that and making a comment will be a difficult part. As Joydev sir has said, that we need a more data. So you can, whoever using the pseudophobia, maybe ICH, Apollo, they can just gather on the what are that actual which patient population are getting better result at what point of time you have started. That will be a very good learning point.
Another important thing is last point is that for immunocompromised, what they are telling, you have to give weekly dose for 4 to 6 weeks, because the immunocompromised is not able to eliminate virus by their immune system. But in immunocompetent, they are able to eliminate the virus just when the viral load is very high, give it. But the thing is that in pediatric population, in immunocompetent child with a disseminated adenoviral infections, how much is the viral load? When the viral load is high, how many days this virus persists? Nothing is known, because disseminated or severe adenoviral pneumonia in immunocompetent children is not that much well known before this 2018 epidemic. Only there are few areas of, I found out few reports from Malaysia and China. They have reported it. Until and unless it's spread in the Western country, we cannot get good data, basically.
That's what I have said. Yes.
Yes,
That's what I have said.
Last comment, sir.
Thank you, everybody. I think this discussion will go wrong, but we have already crossed our time, 11 minutes.
Someone, sir, please 1 minute. Why someone has asked why this time it is so virulent? Sir, one just answer. Some baseline reports are coming that this is probably a hybrid of strain 3 and 7, and there is some input of strain 41. Probably there is something new that this virus is now having with this mismatch of this and this 5 and all this, and that is the reason probably this time we are having this surge.
One
you,
question
Suman.
asked.
Thank you, Suman. No, madam. Already we have crossed 12 minutes. We have crossed 12 minutes.
Last
So we
comment.
have to stop. They can contact you over the phone.
না লাস্ট কমেন্ট একটা মজার আনসার একজন জিজ্ঞেস করেছেন any gene therapy there is for the adenovirus there's no gene therapy in adenovirus, rather adenovirus is used for the gene therapy. My sentence is that.
Thank you.
And the hybrid variety is very rare because it is a DNA virus. Generally, hybrid variety occur in RNA virus. It is a very rare thing to hybrid variety occur in DNA virus. That is one of the important observation in this epidemic.
Thank you, Professor Rai. Actually, we tried to sensitize all our members of the WAP that we should not press the panic button.
Yes.
We should be very skeptic in using the cough syrup, which will not be useful. We'll be using judiciously the antibiotics that Mihir Sarkar has written clearly. We have seen that due to some mutations or the hybridizations, this episode of this severe adenoviral infection we are facing. Actually, Provas has shown us the last couple of years experience in ICH that we are facing this adenoviral toll several times. This year, possibly more cases we are facing. But I am assuring all the WAP members that don't get panicked and try to console the parents that to take the medical advice as early as possible and don't use any cough syrup. And I must thank Dr. Atanu Bhadra. The concept of these adenoviral CME, I call it as CME because I knew so much from you. So adenoviral CME, it is his brainchild, and he said, Shapun, do it as early as possible. And I'm thankful to all my panelists, including Professor Joydev Rai, Dr. Suman Poddar, Dr. Provas Prosungiri, Dibbendu, our own Dibbendu, and Mihir Sarkar, and obviously the knowledgeable Kalpana Datta madam, the president ma'am. So they have agreed that we'll go very fast and do it. So I think all the members will be very much benefited by this CME so that we can take care of the kids of our country. Thank you very much. And I must thank to Somnath. He has done a lot of wonderful jobs. So thank you and good night to all. Bye.
Thank you. Thank you.
Thank you all.
Thank you. And good night.
Good night.
Night.